So for the next presentation, we've got a change of speaker. Jean-Baptiste was here for the Mectizan donation meeting, but has been called away. And so it's my great pleasure to actually introduce Daniel Bouaki. Daniel and I worked on onchocerciasis back in 1982, 83. So we do go back an awful long way, and it was a delight to work with them and on from there. So Daniel's going to talk to us about the APOC closure and the future perspectives in the fight against onchocerciasis. Daniel, have you got slides?
Yeah.
There we go.
Okay. Good morning, and thanks, Janet, and also the organizers for having me here to speak on behalf of Dr. Rungu, who is the director of APOC. And so even though you may find on your brochures that the speaker is Jean-Baptiste Rungu, this is Daniel Bouaki. The presentation will be looking at APOC as a unique partnership, knowing where the disease is, the strategy that's been used, putting research into practice, the achievements and challenges, and the APOC closure, and then perspectives and some suggestions for the future. Even though the title is for more on the closure and perspectives, I decided that I will have this because, as an Akan proverb says, if you do not know where you came from, you will not know where you are going. And so it's important that we cast our minds back to where we came from so that we get to know where we're going. And this is how it all started. With blindness in most parts of West Africa. And when I was growing up, which is quite a long time ago, because interestingly, today is my birthday. And when we were growing up, we saw a lot of blindness around, and most of the time, for those of us from southern Ghana, we thought these were people from the north. And so blindness was always associated with people who came from the north. And the OCP, which came up to control onchocerciasis, had initially the northern part of Ghana as part of its activities. And so the OCP was started in 1974 and ended in 2002. And these were the countries that the program covered, 11 West African countries. And we do see here what became more like the symbol for the OCP, which were the helicopters with the word ONCHO written on them. And these were the helicopters that did the spraying in most of the rivers in the OCP. It was a partnership, as has been mentioned from the earlier speakers, but here the strategy was said that implementation was basically at the WHO implementation level. There were operational activities that looked at collecting larvae after spraying, collecting black flies to find out whether infections are still around in the human populations. The OCP was very successful, and I'm happy to say that we have in our midst one of the former directors of the OCP, Dr. Bouaki. Many times people confuse Bouaki and me, Daniel Bouaki, because. So this was how the endemicity was, the prevalence of infections were in West Africa in 1974. And by 2002, this was what had happened. You may find that there are some places like Sierra Leone which were still very black because of the civil unrest that did happen in those countries. And because of this, the disease, the endemicity or the prevalence increased twice in most of the places around that was going down. And one of the things that I want you to keep in mind is what happens here. Because when you have some issues like this, like what is happening in the Ebola countries, you may end up having some infections moving on to other countries because of the vector migration rate of the vectors. And it has continued with this. In West Africa, mostly blindness was the major cause for the setting up of the OCP. But then for the rest of Africa, this has been some of the severe signs that have also led to the next phase, which is what changed. 85% of the people infected in Africa were outside the 11 West African countries. There was, fortunately, the registration of ivermectin in 1987 for onchocerciasis, and then which it had less of adverse reactions, and it was therefore possible to do mass drug administration. Fortunately, the company also donated the drug free and as long as was needed. And so this led to a public-private partnership that has been the model for the PCE and TDs. So it changed from spraying rivers into people swallowing the tablets. The partnership has been made possible because of the fact that the drugs were donated, and in only a few places was vector control advocated. The partnership has been a unique, and I will go through the partnership because I think that is one of the things that is important. And then also community empowerment. Most of the time when we talk of APOC, people think it's a secretariat, but APOC is a partnership. A partnership that has a secretariat that manages what the partners decide. This partnership has the participative governance of countries, developing partners, sponsoring agencies, NGOs, the drug donation companies, and then intergovernmental regional or sub-regional organizations. The management, which has now become synonymous with the partnership, is being managed by the WHO African region. It follows the norms and guidelines of the WHO, and it has a semi-autonomy because most of the time at the end of the year there is a joint forum of all the partners, and this forum decides on activities and that has to be undertaken by the management or the secretariat. It has a sustaining partnership that includes the poor in decision making. It engaged governments and other stakeholders, and so within countries you have the National Onco Task Force that is made up of all the partners within a particular country, and then the Onco Secretariat of the Ministry of Health. And then you have active participation of endemic communities. And here we talk of whether you're having community-driven or community involvement. And these should be seen as different. The drug donation has been a very critical component of this partnership. Funding, the NGO group have also been sourcing for independent funding. So apart from funds that come through the trust fund, you do have funds that go through the NGOs. And then the involvement of the scientific community has been very important. Some of the activities have been mapping to know where the disease is. And here with APOC, you have over 14,000 villages surveyed and over 576,000 people examined. Based on this manual that was developed for rapid epidemiological mapping of the disease, it's been a tool that has been, REMO has been a tool for planning and targeting areas for disease control interventions. And it has helped in reasonably getting to know where the disease is and how it has to be controlled. This is the Remo map at the beginning of the country. Currently, we talk of shrinking the map, and so the areas that you see in red have different colors. Nationwide mapping was achieved in 19 countries with a population at rates of over 85 million and population infected of 36 million. The strategy which I meant by the community involvement was finding out whether communities themselves can design or help in designing, implementing the distribution on their own, and which delivery method was capable of eliminating ONCHO as a public health problem, designed for the community or designed by the community. Research that was done in this context led to the fact that the community can carry out distribution of the mectizan tablets effectively. They can give the correct dosage, exclude those who should not be treated, and report on the distribution. And so this has been the principal drug delivery strategy since 1997, and based on this, which has become the trademark of APOC, it was possible to move, if you look from here, before APOC, how treatment was being done by mobile teams going into communities from the ministries, and there was a rapid scaling up the moment the communities themselves were made to be part of this activity. They decide when they treat, they decide who they select to do the treatment, and based on this, because the distributors were from the communities and were selected by the communities, there was a rapid scale up of interventions. There's always research at the base of whatever happens in control of onchocerciasis. And knowing where some of your challenges are, for example, the challenge of lower. And here I want to mention Professor Molino, who was part of a team that studied the spatial overlap of ONCHO and lower. And then based on these reports, the development of the RAP lower as a rapid assessment technique for knowing where lower is and then mapping lower is. There's been also some research on the effectiveness of community-directed treatment and entomological evidence to support elimination of some of onchocerciasis in some areas like the Bioko Island. And this was because this study, which was done by Professor Post, who is at the John Moore University here in Liverpool, and colleagues, who was also working at a point as a consultant for the Onco Control Program, found that this species, Similium yahensi, from the Bioko Island was unique, and therefore if it's eliminated, it will stop the transmission of onchocerciasis. And so on the Bioko Island, there's no transmission of onchocerciasis because the disease has been eliminated. And I think I can also see Philip Markle sitting in the crowd here. Studies also have been used in moving the strategy from control as a public health importance to elimination of onchocerciasis. And this was the studies that were done in Mali and Senegal. Currently, there are also studies to have traps that could replace human landing collections. Ivermectin response studies are also being done, and also other drugs are being in development. Though APOC has achieved a lot of successes, economic impact has been estimated as over more than $10.1 billion prevented. There's been capacity built in the countries, and also the health systems in these countries have been developed. There's been a model for PCNTDs, and some of the CDDs were more important in also contact tracing during the Ebola crisis. Some of the achievements have been that the control has been so successful that in many areas now infection is almost close to zero. Some 400,000 people have been protected from low vision and blindness. The use of ivermectin has also been important in lymphatic filariasis and some of the other NTDs. Cumulatively, over 918 million treatment of people have been treated since APOC started. And these are co-implementation, as was mentioned by Dr. Upendo, that in some countries now, mass drug administration for ONCHO is being co-implemented with other interventions. There are still challenges. Lower co-infection is still a challenge. The funding gap is still a challenge. Managing the partnership, because with different partners, each has their own interest, even though the general interest is for control of the disease. Yet, you will still have each partner of a particular interest. There's a need to complete mapping for treatment because of the hypoendemic areas that need to be included for elimination to be achieved. And then there are areas where pre-treatment levels were very high, and therefore the number of years that were planned for treatment may be longer than anticipated. Entomological capacity in the countries is lacking, and this is something that APOC has been trying to change. And then there are challenges with the Ebola countries, and as I mentioned much earlier, the threats they pose to other countries in the sub-region. APOC closes on 31st December 2015. Main activities are supposed to be continued until the closure date. But then there is the separation of staff as from June. And so how this is going to be achieved is still something that is being discussed. There are delays associated with funding and hence major activities. Some of them have not started even though we are in April. And then there is uncertainty about the future because till now we're not sure of what is coming at the end of APOC. This leads to some perspectives. Are we going to meet the targets set by the WHO Roadmap and London Declaration? If there are interruptions in treatment, there is the possibility that if treatment is stopped, as we've seen in Sierra Leone and what happened to Guinea, and also in Ghana and Cote d'Ivoire and what is happening in Burkina Faso. Because especially in some of the areas in Africa, the flies, which are the vectors, do undertake long-distance migrations, sometimes up to 300 kilometers. Even though in most places you have the movement just around 30 to 40 kilometers. And so if you interrupt treatment in an area where the vectors can do long-distance migration, the possibility of affecting other areas is real. Challenges for countries without partner support. Because sometimes when we go into partnerships, bilateral partnerships with countries, we do realize that some countries are left out because either the government in that country is not a favorite of the donor community. And so you may not then have that particular country having any support. And so you may end up with orphan countries. There are situations of conflict and post-conflict countries, and these are things that we should ensure that all these areas are fully covered by mass drug administration. It is mentioned that countries might be in the driving seat for mass drug administrations, but there is still, in my opinion, the need for a centralized regional entity to help coordinate and help countries in some of these activities. Some of the suggestions will be creation of a regional structure. For now, we're not sure whether there's going to be one or not. there should be effective ownership and leadership by countries. And here I do mention that sometimes when we have some of these fora, we do invite either program managers or we do invite the Minister of Health, but hardly do we get very high-level political people in some of our sort of as invited guests. And therefore, the Minister of Health will go back and say, well, I have to report to Cabinet. And so we always end at a level and we never move up from there. I think it's important that sometimes we get some of these the presidents or some of these high political leaders sitting in some of these meetings. Financial contribution by endemic countries is a challenge. But we need sometimes to also invite some of the philanthropists from Africa to sit in some of these meetings and let them feel that they are also important and contributing to a good cause. Because if we don't do that, well, they'll be using some of the monies that they find in just supporting some of the beauty pageants that go around and not the NTDs. We have to address cross-border issues. And here I think we should take a cue from the OCP in West Africa, where there was a memorandum of understanding for all countries to have people moving across the border as long as they were working for the OCP. And then we should sustain and further improve the achievements of the OCP and APOC. In conclusion, I would say APOC and its predecessor OCP have been among the most successful public health programs in Africa and have become models for other NTDs. As APOC closes on December 31st, the apprehensions about whether the investment made could be protected and the achievements attained could be maintained. We should all make an effort to prevent going back to where it all started, even in one endemic country. We should not go back to this. Thank you.
Thank you very much, Daniel. And I think all of us are waiting to see what happens post-APOC and how we make sure that the partnerships, not only for ONCHO, but the other NTDs in these countries continue.